panelists. So Dr. Nitesh has already introduced Dr. Puneet, who's a pulmonologist at Max Institute of Cancer Care. Dr. Pramila, she heads the Department of Nuclear Medicine at Max Institute of Cancer Care, Shalimar Bagh. Dr. Kanika, she's a radiation oncologist and she heads the Department of Radiation Oncology at Dharamshila Narayana Super Speciality Hospital, Delhi. Dr. T. Raja has joined us from Apollo Specialty Cancer Hospital, Chennai. He is an eminent medical oncologist. And then we have our young, energetic surgeon, Dr. Shubham Jain from Max Institute of Cancer Care, Delhi. So I'm going to make you walk through a case straight out of the clinic. So he is a 63-year-old gentleman, Mr. AB, who doesn't have any comorbidities, and he is a chronic smoker, 20 pack years. He presented in January 2020 with complaints of cough with expectoration, intermittent since 2 years, increased since last 2 months, off and on low-grade fever since 2 years, and then breathlessness on exertion for 2 months. He has a massive weight loss of approximately 11 kgs in 6 months, and there is no hemoptysis or headache. So from the history, I mean, we can see that patient has chronic as well as acute onset of symptoms. And we know these two things, tuberculosis and lung cancer, they overlap a lot. So a chest X-ray was done, which showed an ill-defined opacity in the right mid-zone, and a CT chest showed a ill-defined parenchymal opacity in the right upper lobe and nodular opacity in the right middle lobe. And there were mediastinal lymph nodes, pretracheal, precarinal, and subcarinal lymph nodes. Here you can appreciate that there was ground glassing with interstitial thickening in the right upper lung, upper lobe with interlobar septal thickening. So my first question to my panelists, to Dr. Puneet, is how do you interpret this ground glassing with interstitial thickening, which is confined sharply to one lobe? Dr. Puneet?
Hello.
Dr. Puneet, you have to unmute yourself.
Yeah.
Yes,
I'm audible now? Yeah.
Yes.
As we know, this opacity is irregular margin and in upper lobe with certain ground glassing. This presentation can be of two types, in tuberculosis also and CA lung also. So we should further diagnose it with bronchoscopy or EBUS or see the lymph node involvement in the lung window. Okay. As we see, interstitial thickening is there. It could be due to past any granulomatous illness causing fibrosis, and after that superimpose lung cancer or tuberculosis or secondary infection again.
Okay. So he didn't have any past history of any granulomatous disease. And do you think it can be obstructive pneumonitis or bronchiolitis presenting like this? Because normally miliary or lymphangitic would be, bilaterally and in bilateral lungs. So you would be seeing more of these confined sharply to one lobe kind of interstitial thickening.
Yeah.
Dr. Bromel, any comments from your side?
Am I audible?
Yes.
Yeah, seeing from the CT images, it looks like it could be the CT gives more of a picture of it could be infective pathology because there are more of a ground glass haziness, and as such there is no mass seen anywhere, and it could be because the CT findings are more look like to be infective rather than mitotic, just seeing on the CT images.
Okay, thank you, Dr. Pramila. So, Dr. Puneet, how would you like to proceed in this case?
First, we should do the bronchoscopy. If sputum is available, then we can go for sputum examination for malignant cell also and for tuberculosis to rule out. And for bronchoscopy, we can study the lymph node status by EBUS technique and can take the sample of the different lymph node involvement, and simultaneously with bronchoalveolar lavage, we can study the gene expert for tuberculosis or culture sensitive for any infective pathologies, and in addition to this, cytology for malignant cell to see if any cancer pathology is there or not. As we see the histories of chronic smoker, the chronic smoker are both predisposed to cancer also and tuberculosis also.
Great, great, Dr. Puneet. So that is what our patient underwent. So outside he went a bronchoscopy, which showed that the right upper lobe was completely obstructed with the lesion, and there was infiltration in the right middle lobe on the lateral side, which was 1 centimeter away from the carina, and left bronchial tree was normal. The biopsy was taken, and it came out to be a moderately differentiated squamous cell carcinoma. So I would now like Dr. T. Raja to step in and tell us, I mean, what is the emerging role of molecular markers in a squamous cell carcinoma of lung? Dr. T. Raja.
Thank you, Dr. Garg, for inviting, and thank Dr. The entire NALCON team for this invite. I just want to also add to what has been asked to our pulmonologists, but of course, it's now a retrospective knowledge that I now have the bronchoscopy in front of me and then the findings. So the whole thing is kind of an atelectatic lung, post-atelectatic, change. This is often well explained by CA lung as the probability, and again, the disease is located quite close, 1 centimeter away from the carina, and as was seen in the bronchoscopy, there's a bit of an obstruction. So I think that explains the radiological picture. So I'll be very keen to know that, because I want to have the bronchoscopy done. I want to get the EBUS done. I want to look at those lymph nodes. And I really want an FNA of those lymph nodes as much as possible to make sure that our lymph nodes are also well defined. So
We'll give you that.
that's what I want to add here to what has been already told. With regard to your question about squamous cell carcinoma of the lung, and I think the MO is probably medical oncologist, I suppose, and it's not an M0 that you're asking.
No, not at all.
And so in nowadays, we are kind of a little open with both squamous and non-squamous, and our upfront reflex testing is involving both for squamous and non-squamous. I would send a complete panel in all our patients in the metastatic setting. I'll be looking for all the markers, even in squamous cell. Of course, the percentage of driver mutations are definitely higher in the in the adenocarcinoma, but again, we know that there are expression of these mutations, so on and so forth, and we definitely have treatment decisions to make on these changes. So I'll be asking for almost a similar panel what I asked for adenocarcinomas.
Thank you, Dr. T. Raja. So I think that is a change which we have seen recently, and now we are sending our driver mutations for squamous cell carcinomas, particularly if the patient is a non-smoker, young, or if you have a small histology biopsy sample, or it is a mixed histology. Great, thank you.
PL1 goes automatically for all of us, all of the patients.
Okay, thank you. So this was the PET CT which we got done, and as you can see that there is an FDG avid thickening in right hilar, suprahilar region, and reaching up to the costal pleura anteriorly, encasing the right main bronchus, and then there were discrete and confluent nodular opacities in the right lung upper lobe, and multiple FDG avid lymph nodes. And there were no other FDG avidity seen in the body anywhere else, and ground glassing with interstitial thickening in the right upper lobe, which you had seen on the CT as well. So, I mean, these I've just put to show you how clearly demarcated it is confined to one lobe. So now my question to Dr. Pramila. Dr. Pramila, is there any PET criteria to differentiate these lobes from pathology vis-a-vis a malignant pathology?
So as such, there is no absolute criteria to differentiate benign versus malignant. Although so much has been said about SUV max, which we always report in our reporting, but SUV max is the metabolic activity level of any given lesion, which is dependent on so many things, like how much is the tumor size, how much is what is the histopathology of the lesion. Like in cases of there is so much overlap between infection versus mitotic activity. They are also hypermetabolic to tumor and infection, both are metabolically active. So on the basis of just SUV, we cannot differentiate between benign versus malignant. At the same time, like you can get various false negative ratios in cases of small lesions. If the lesion cellular, even mitotic lesion with low cellular activity, like in cases of mucinous adenocarcinoma, we may get false negative SUV values. But at the same time, we have got very high uptake in cases of tuberculomas or various infections. So there is no absolute criteria when you are reporting PET findings. You have to see everything in toto. Just reporting SUV or image finding, you may land up in doing so many mistakes. So we have to see everything. We take into everything into patient history in context, scan finding in context, and sometimes the clinical opinion of the physician, which gives us a very much insight, deep insight into the patient. And then we report everything in complete totality. So no absolute criteria.
So that is why now we have residents in the nuclear medicine department also who exclusively takes the history of the patients.
Yes.
And like very brightly, a meta-analysis concluded that the FDG PET can diagnose malignant pulmonary lesions with an estimated sensitivity of 94.2% and specificity of 83.3%.
Yeah, it depends. Like in cases of, if the SUVs of the lesions are very high, then the chances of this being mitotic is high, but this is not an absolute area. So that is why we take a very detailed image of all the patients which we comes to us. So it's not just, we are not reporting only the scan findings. We that is why nuclear medicine persons are called physicians. So we are physicians. So we have to take everything into totality.
Coming back to you only, Dr. Pramila, according to you, like in how many cases, percentage of cases, would a PET CT would upstage or downstage a lung cancer patient?
So if you see, in case up to 40% of cases, the change whether they are either upstaged or downstage, depending upon the PET results. Upstage because in cases of because PET is very good in detecting delineating the mediastinal lymph node staging, as well as it sometimes in more than 10% of cases PET gives you unexpected metastasis can be detected, because here we are screening the whole body of the patient. So on the basis of that, it changed the TNM staging up to 40%. And it changed the management of patient in case up to, one study has reported up to 72% of cases, and almost in 1 in 5 patients we can reduce the chances of doing unnecessary surgery or unnecessary intervention, because we find patient have distant metastasis or nodal staging is high. We detect N2 staging in cases of lung, then in those cases there is no use of doing any futile surgeries. So it changed management up to 40% of cases of patients.
Very rightly said, Dr. Pramila, 40% upstage, 10% downstage, 10% unexpected meds. So that's a huge figure.
That's a huge figure.
Yeah. So as Dr. T. Raja was saying that he would like to know the status of the lymph nodes. So we know that even if we have a proven primary, these nodes, they cannot be taken at its face value with an increased FDG avidity. We know that EBUS is the preferred modality for assessing the nodes. I would like to ask Dr. Shubham, is there any particular situation where you would sort of prefer mediastinoscopy in addition or over to EBUS?
Hi, Dr. Charu. So, EBUS and mediastinoscopy, I would keep them as complementary to each other rather than supplementary. So, an EBUS definitely has a role prior to a mediastinoscopy, but just in case where logistics are not feasible, or that the EBUS has been reported as negative, but the clinical suspicion still continues to be high, I would definitely prefer to subject the patient to a mediastinoscopy, which is the gold standard for mediastinal staging in those cases.
So, I mean, is there any lymph nodal stations which you cannot access by EBUS and you can do by mediastinoscopy, or the amount of tissue which you get in EBUS vis-a-vis mediastinoscopy, is there a difference in that?
So EBUS essentially provides us an FNA tissue only. So if there is a possibility at sometimes in cases where we are not able to get a diagnosis of more than a poorly differentiated carcinoma. So definitely where we need more tissue to do IHCs, there definitely mediastinoscopy is preferred. So the need for more tissues is definitely another indication where we would prefer it over an EBUS. but it's not, as I said, it's not a supplementary modality, it's a complementary modality. So when we have a primary in the lung, as in this case, and there are mediastinal nodes, then definitely mediastinoscopy would help us in establishing the status of nodes, even in case EBUS is negative and the clinical suspicion continues to be high.
Okay, thank you. So mediastin, for logistics reason, we could not do a EBUS, and this patient underwent a mediastinoscopy with lymph node biopsy, and there were enlarged lymph nodes seen in 2R, 4R, and subcarinal region. And biopsy, as you can see, that level 2R showed a metastatic deposit of moderately differentiated squamous cell carcinoma with ECE, and level 4R and subcarinal node shows non-caseating granuloma with no tumor deposits. So I will come back to Dr. Puneet. Dr. Puneet, how do you now sort of manage this case where you have granulomas and you know that you have got a diagnosis of cancer?
Yeah, actually, in this tertiary setup, we are getting some lots of patients referred from periphery, where there is history of tuberculosis treatment and this upper lobe shadows is not going after serial X-rays. They miss the diagnosis of cancer. Then we diagnose them as a lung cancer, which initially was examined by peripheral doctor as a pulmonary tuberculosis. There are two type of cases, either wrongly diagnosed or correctly diagnosed as a tuberculosis case coexisting with the lung cancer. So due to past history of tuberculosis also, if there is any scarring, there is increased chance of developing lung cancer if patient is having chronic smoking history. So we start the ETT according to the condition of smear result or this culture result, and simultaneously if patient is having coexisting cancer, lung cancer also, then we uh, start this cancer therapy also according to our oncologist colleague, and we simultaneously treat both.
Okay. So hold of DDs for non-caseating granulomas, which would a few of them will be pertinent to India, not all. And so Mr. AB was started on AKT after investigations, and the final staging, it was staged as T3N2, stage 3B. So I would like to ask Dr. T. Raja, how often do you see tuberculosis and cancer coexisting in your clinical practice?
I mean, to the contrary to the belief, I just want to state whatever I see. Again, that may be different from different hospital experiences. Basically, because different hospital means we're talking about clearly different socio, economic background. So I have to humbly state that at each hospital, at whatever level, the experience may be different. Again, that's only my impression. I don't see tuberculosis coexisting with, in this case, lung cancer that very often as I would like to imagine, even though there are patients of tuberculosis that I can see with any of the malignancies mixed up. But in my opinion, I would, if I have to hazard a guess, probably only 5% or less than, definitely less than 10% in our setup. That's what I want to add. Maybe the experience is different in a larger general hospital. Now, I just want to go back to, if you permit me, I'll just add a couple of things to whatever surgical oncologist had added. The whole purpose of evaluating the mediastinum is to define the loco-regionality of the disease and what do you want to do. And therefore, if you look at the sensitivity and specificity of each of the investigations. Of course, PET CT, as was rightly mentioned, a certain sensitivity and specificity. Therefore, you want these investigations, invasive investigations, because you want 100% specificity, then you go for all these invasive. If you do a EBUS US, that can actually supersede a mediastinoscopy in sensitivity and equal mediastinoscopy in specificity. Only if EBUS US is negative and then there is a clinical suspicion, we don't know what is there on the PET, then the mediastinoscopy is a good investigation. And again, if a tissue was exactly like you pointed out. Here, my point here is that only one node, that is the upper paratracheal 2R, is positive, and the rest of the 2 lymph nodes were negative. So this is a single station N2. And going back to the anatomy of, if it was originally T2, but if I have to consider 2-lobe lesion, it is a T4, and it's a T4, and a single station N2 may still be a good candidate for surgical consideration. So I want to be very, very clear on all that.
Sure. So it was basically T3. It was just one lobe, and there was some nodule seen in that one lobe. So
I thought you showed upper lobe and middle lobe. If
so
I'm
it was
not
just
wrong.
the only part of the, the bronchus was infiltrating.
Okay.
Yeah. So as Dr. Puneet also said that, a study conducted by the NCI, they found that patient with pulmonary tuberculosis had increased of lung cancer. And another estimated a 2-fold elevation in risk of lung cancer in men with tuberculosis. And tuberculosis will increase the risk of lung cancer through substantial prolonged inflammation, host tissue damage, fibrosis, scar formation, and genetic alterations.
So this is from NCI, basically from United States incidents. Do we have the Indian? I'm sure our pulmonologists definitely have a lot of it.
Yes. In fact, the other thing also what they said that, the coexistence of TB and lung cancer, they estimated at 2%, but I'm pretty sure in India, we would have it more. I couldn't really find the data for that.
There are some data from Kolkata, Dr. Kakuli et al. They have done certain retrospective studies. So they also have found around 3 to 4% incidence of tuberculosis with lung cancer. They segregated them as those who had 2 months previous to the diagnosis of cancer, synchronous, and during the course of treatment. So they've quoted around 3 to 4%.
Okay. Thank you, Kanika. So, what Dr. Puneet was discussing, because of the pulmonary tuberculosis and lung cancer coexisting, there can be a delay in making a diagnosis of approximately 11.7 months as it was in this study. So a high index of suspicion of double pathology is warranted in the setting of a predominant or a growing nodule during the treatment for active tuberculosis. So now I would like to come back to Shubham. Shubham, would you like to operate on this patient? If we say it is if it is a single station node which was positive and a T3 lesion, would you like to operate this patient upfront or after NACT?
So with the mediastinum positive, definitely upfront surgery is out of the question. What we could debate here is the disease burden in the mediastinum. So I believe that the node, because it was showing extracapsular extension as well, and it's a T2 lesion causing obstructive changes in the right upper lobe, this can fairly be considered as a disease with a bulky mediastinum disease burden. So we definitely need to start this patient on NACT, and we can then assess the response based on that. If the mediastinum still continues to be positive, then definitely this patient goes for a chemoradiation. If following that we are able to achieve sterility of the mediastinum, we may consider, depending on the fitness of the patient, for a surgery vis-a-vis a radiation. But if we consider the extracapsular extension as a marker of bulky mediastinal disease burden, definitely surgery is out of the question then.
Okay. Thank you, Shubham. So I'll skip this question that in case if you have to operate, once the patient turns negative in 2 or 3 weeks time, then we can, operate that patient. Now coming back to my medical oncologist and radiation oncologist, I would like to ask Dr. Raja first, followed by Dr. Kanika. How would you like to sequence the treatment of this patient of anti-COX treatment, chemotherapy, and radiation? Dr. Raja.
Yeah, I mean, once our surgeon is happy to let us deal with the patient, then comes the standard of care is CTRT, and the only variable in this patient is a possible tuberculosis. Again, it's only a non-caseating granuloma. Again, if I have to just raise some, what if this
Charu,
is something
sorry, just one. Charu, sorry,
Yes.
interrupting. Just 2 minutes left, so we'll have to close
Okay.
this soon.
Okay.
Thank you.
Okay, then I would just start AKT, wait for 1 or 2 weeks, and get going. That's what we do.
Okay. So I'm not going to ask Dr. Raja this. So basically the role of durvalumab is there in squamous cell carcinoma also, and we don't need any molecular markers for doing that. I would like to ask Kanika, like which radiotherapy technique would you, advise the patient, and how has the modern techniques changed the outcomes of advanced lung cancer?
This particular case, I would say, is the standard case which I would select for an image guided radiation, because this patient has obstruction, is likely to have opening up of the bronchus during the course of treatment, and the entire anatomical changes need to be followed up, because you will have to adapt your radiation portals as per the opening up of the lung. So image guidance, I think, is the preferred treatment here. And with adaptive being considered somewhere between 3rd week to 4th week, as the lung parenchyma opens up, you can redefine your tumor volumes, and PET-based planning, because PET can guide you in terms of your volume delineation. And surely I would prefer to treat it after some clearing of the tubercular changes, because PET, as Madam Pramila said, would not guide us in telling that which is disease and which is tuberculosis. So at least tuberculosis clears up, then your volumes are better defined. So adaptive under an image guidance. It will also reduce the pneumonitis if it is performed aptly.
Yes, so the retrospective studies basically have shown that there is a improvement in survival, but our RTOG 061, which was a prospective trial, showed no improvement in survival, but yes, radiation pneumonitis, the cardiac doses, everything was less. So I